Okay, I think we can get started. Dear participants, my name is Gab McDonough, and I am the Educational Action Supporting Officer at ERN-EuroBloodNet, the European Reference Network for Rare Hematological Diseases, and it is my great pleasure to welcome you to the ERN-EuroBloodNet Thursdays Webinars. The aim of these educational activities is promoting the interest on very innovative topics in order to stress among health professionals the cutting-edge advances in the field of rare hematological diseases. Webinars are mainly addressed on very rare diseases, complex disorders, highly specialized procedures, and implementation of guidelines. At the same time, webinar programs that are specifically addressed to patients intend to increase awareness on a specific rare hematological disease among patient advocates and patient associations. Before we start, let me share some home rules. Please note that the session is being recorded and will be uploaded onto the EBN e-learning environment on YouTube. If you do not wish to appear, please turn your camera off and change your name on the platform. Also, please be kindly informed that your microphone is muted. If you have any questions about the presentation, please write them in the chat. They will be addressed during the Q&A session at the end of the webinar. Today's webinar is on the treatment of anemia of low-risk myelodysplastic syndrome, and the speaker today is Professor Platzbecker. Professor Platzbecker serves as the director of the clinic and Polyclinic for Hematology, Cell Therapy, and Hemostaseology at Leipzig University in Leipzig, Germany. Professor Platzbecker's research is primarily dedicated to myelodysplastic syndrome and its treatment. His team has conducted trials on Luspatercept and Imetelstat for patients with low-risk MDS, as well as a recent phase 1 trial investigating a new oral IRAK4 inhibitor for relapse refractory high-risk MDS or acute myeloid leukemia. And with that introduction, I hand you the floor, Professor. Thank you very much for joining.
Thank you very much for having me. I think you provided the stage also for the topic. What I will do, because I think it's quite timely, I will also strive for a couple of minutes high-risk MDS at the end of my presentation, but will predominantly, of course, talk about low-risk MDS and recent advances in the field. So I get started. And these are the learning objectives of the webinar. I think I will talk about MDS classification and prognosis systems because this has implication on how to select patients with either lower risk and higher risk MDS, and of course also predominantly how to consider current treatment options. So this is the evolution of prognostic scoring systems, and I think for a long time the IPSS was the one predominantly used in the clinic, where patients were prognosticated based on bone marrow blasts, cytopenias, and cytogenetics. The revised scoring system implemented 5 different cytogenetic prognostic classifications. And as a matter of fact, we have now more groups to consider, and I will show this in a second. And last but not least, the IPSSM also includes now molecular abnormalities, and based on this, you can estimate the prognosis of given patients. So I think still the IPSSR is the most widely used, and you see that we have lower risk and higher risk patients. Very low and low are definitely lower risk, high and very high are higher risk patients. And the intermediate box, the median survival is 3 years, which one may say is pretty good. Others may say that's rather limited. Therefore, there's a wide range, and I definitely recommend a molecular workup in those patients in order to estimate the precise prognosis and to calculate the IPSSM. So, but for the sake of this presentation, I think low-risk MDS patients are within the very low, low, and intermediate box. So these are patients with cytopenia, predominantly anemia, with bone marrow blast of less than 5%, and with a life expectancy exceeding 2 or 3 years. The recent molecular evolution has also found some implication into the WHO classification, where patients with del(5q) are part of it, as also of the old classification. But now SF3B1 mutated patients are considered a specific subgroup based also on their characteristic phenotype, but also genotype. And then we have patients with low blast, hypoplastic MDS, where, for instance, ATG can be considered, and all other patients, including those with a B allelic P53 mutation, are considered higher risk. So start with a lower risk subgroup, and this looks very busy, but at the end of the day, it's not, and I will guide you through this cartoon in the next couple of minutes. So let's start with patients with symptomatic thrombocytopenia. Nothing can be offered apart from TPO receptor agonists like eltrombopag and romiplostim. Both have been shown to be not only safe, but also efficacious in roughly 50% of the patients. Nevertheless, they are not approved, and therefore, I think at least that's the way we do it in Germany, that we ask the insurance company for financial support. Second, and also a rather small group of patients are those with symptomatic anemia and del(5q) disease. In patients with del(5q) disease and TD, which is transfusion dependency, lenalidomide is already the standard of care. However, there has been some recent development in NTD patients, non-transfusion dependent with del(5q), because a European trial led by our colleagues from Spain randomized lenalidomide versus placebo in patients with non-transfusion dependent del(5q) disease, newly diagnosed, and you see that the time to transfusion dependency was significantly extended compared to the patients receiving placebo. Survival was not changed, but I think this improvement I think is clinically very meaningful, and therefore I think the current guideline should also consider to use Revlimid or lenalidomide at a dose, however, of 5 and not 10 milligram in those patients. This may also allow for a cessation of lenalidomide in del(5q) patients who actually achieve a sustained response. Now, the third large group of patients is the so-called non-del(5q) low-risk patients. And again, we have a breakdown into NTD and TD patients. So the NTD patients, non-del(5q, anemic patients should be treated with ESA-based therapy, also based on the EPO level. Patients failing this kind of therapy with an hypoplastic bone marrow can receive ATG, cyclosporin A. All the other patients, and this is a non-del(5q) disease, again, being transfusion dependent, I think there we have the choice, and I will actually guide you through the recent developments and also the data supporting this kind of approach. So number one, Luspatercept is already, or was actually already approved as a second-line therapy for patients with ring sideroblastic MDS failing ESA-based therapy. A recent update showed that 50% of the patients achieve a response, and patients responding also had a survival benefit compared to patients not responding. The PACE trial actually showed that the earlier you introduce Luspatercept, the higher the response rate. This is the response rate for patients being non-transfusion dependent, and therefore the ELEMENTS trial is something which I will present in a couple of slides. But before, the COMMANDS trial was actually designed as a first-line head-to-head comparison in patients with IPSS-R very low intermediate risk, being ESA naive, and no prior treatment. And this study included both RS positive, RS negative patients with a head-to-head comparison. The study was powered to show superiority and for Luspatercept, and interestingly, again, an enrichment of ring sideroblastic patients was shown in the trial, 70% of the patients. Otherwise is what you would expect from a low-risk transfusion-dependent population. The study met its primary endpoint. Luspatercept was superior compared to EPO alpha with regards to response rate. Also, the durability of response was longer for Luspatercept compared to ESA-based therapy. What about subgroups? So I think there was a superiority across all subgroups with one exception, and those were the patients being RS negative, where actually both treatments achieved the same response rate or comparable response rate, I would say. So this leaves us with a choice, which is, I think, according also to the label extension of Luspatercept. As you know, Luspatercept label was recently extended also now to patients being EPO or ESA naive. And this is actually shown here, RS positive patients, SF3 mutated patients, where Luspatercept, at least in the COMMANDS trial, showed a superiority. I think for patients with an EPO level of more than 200, Luspatercept should be given definitely to every patient. In patients with an EPO level of less than 200, Luspatercept is achieving a better response. However, the patients, of course, may consider self-administration of ESA because this leaves them more flexibility. Therefore, in general, there is the choice also for the patient, but also for the doctor. Still, in patients failing ESA, Luspatercept would be available as a second-line therapy. In the non-RS SF31 not mutated cohort of patients, again, you would have the choice because Luspatercept is approved there, but is not superior compared to ESA-based therapy. Again, this needs to be discussed with the patient. So then you see a lot of failure boxes here, and this, of course, leaves room for second or third line therapy based on a recent development, and this is the telomerase inhibition with Imetelstat. Telomerases are, of course, essential genetic elements, and they are required for cell immortality, and they are actually highly upregulated in malignant stem and progenitor cells, thus enabling continued and uncontrolled proliferation. This has been shown in leukemia, but also in MDS, and this was the rationale to do a 2-to-1 randomized trial in patients with transfusion-dependent lower-risk MDS, comparing Imetelstat versus placebo in this high transfusion burden patient population. You see that transfusion load had to be at least 4 units of red blood cells within 8 weeks. Those are the patients included. You see, again, an enrichment for the ring sideroblastic population, 62%. And important to say is that the majority had actually a high transfusion burden, roughly 50%, more than 6 units of red blood cells within 8 weeks, which I think is pretty considerable. Important notion is that the prerequisite for the successful therapy is that the neutrophils and the platelet count is basically within the normal range. And this is due to the fact that this drug induces neutropenia and thrombocytopenia grade 3 to 4 in 60 to 70% of the cases, with, however, no differences in grade 3 or more bleeding or infectious complication events, but still it's reversible in the majority of the cases, but needs to be considered and monitored during the surveillance of the drug administration. Most importantly, the study met its primary endpoint. You see a superiority with regards to the transfusion independence, 40% versus 15%. Also, I think for this hard-to-treat population, an 18% one-year transfusion independence rate is quite encouraging. Does this drug work in all subgroup of patients, or is the preferential activity in ring sideroblastic patients? No, it's not. You see that across all the subgroups shown here, Imetelstat actually was superior compared to placebo. Interesting observation was the fact that patients responding also had a reduction in the ring sideroblastic counts or SF3B1 allelic burden, TET2. So the drug seems to have some modifying activity on the malignant clone in the bone marrow. So Imetelstat was recently approved by FDA. The EMA decision is pending, but if so, it would be an all-comers second-line therapy in patients failing or not responding or losing response actually to either ESA and or Luspatercept-based therapy. So what are other recent developments in low-risk MDS? Just highlighting inflammasome activation as a main driver of ineffective hematopoiesis in the bone marrow. There are some recent drugs actually looking for interference in these pathways to improve hematopoiesis and also blood counts. Also, allogeneic regulatory T cells to target bone marrow inflammation have been recently piloted in a phase 1 trial in patients with bone marrow failure. So still the jury is out where this will go, but I think it's a current target in low-risk MDS patients. Second is higher risk, and I would just highlight the recent attempts to improve the standard of care, and this is basically azacitidine as a monotherapy in the majority of our patients. Some patients, roughly 10%, are also eligible for allogeneic stem cell transplantation, but the majority will receive azacitidine monotherapy. There have been a lot of trials combining novel agents like pevonedistat with azacitidine or decitabine in high-risk MDS. And these phase 3 trials were based on very encouraging phase 2 studies. This is the phase 2 trial. The phase 3 trial was actually negative and did not show a significant difference. Here, the same for magrolimab, a checkpoint inhibitor, very encouraging phase 2 data. Phase 3 trial also was negative and has been already presented at a conference. Sabatolimab, again, encouraging phase 2 data, even randomized phase 2, but the phase 3 last ASH was the presentation actually also did not show a superiority of the combination versus azacitidine monotherapy. And just yesterday, a press release by Cyrus, tamibarotene plus azacitidine in high-risk MDS patients, the top-line results from the phase 3 SELECT trial also showed no superiority of the combination with regards to azacitidine monotherapy. So therefore, the hopes are here for the outcome of the Verona trial. It's an AZA versus AZA venetoclax randomized phase 3, which is also planned to be reported by next year and then could become the new standard of care as it is in elderly AML patients already. So where are we now? I think we are on the way, hopefully also to precision medicine. I showed you recent updates, tamibarotene. I didn't show you roxadustat. There was also a negative trial just recently reported. There's some hope in immune-directed therapies, but I think Imetelstat and Luspatercept are the two new players in first and second line of low-risk MDS patients being transfusion dependent. I think this is great success, and we also hope for the EMA approval in the next couple of weeks. So still for our patients, this leaves a lot of hopes. And I would say our hearts are big, but the possibility is still limited. I think we need more trials. We need better design trials. And of course, also a little bit of luck in order to improving and extending the armamentarium for our low-risk MDS patients. With that, I'm happy to take questions, and I'm at the end of my presentation.
Great. Thank you so much, Professor, for your presentation and for including both lower risk and higher risk. That's excellent. As previously mentioned, please enter any questions here in the chat for the professor. I'm sure I'll be happy to take any of those questions. In the meantime, I would like to make just a quick announcement for our upcoming Thursday webinar. Which will be by the speaker Valeria Santini. And the subject of that presentation will be, when is molecular analysis useful in myelodysplastic syndrome? And that'll be on December 19th at 5 o'clock, which will be the last Thursday webinar of this year. As previously mentioned, these webinars are really aimed at the cutting edge, and I think this was very much presented here in Professor Platzbecker's presentation, including yesterday's results, which is incredible. And the real advantage of this webinar series is to make this information available on our YouTube educational channel so that this information can be promoted even further. Perhaps I'll ask one more time if there are any specific questions for our professor today. Please feel free to enter them into the chat. And if not, do you have any closing statements, Professor?
The future is bright if there will be peace and we will behave.
Perfect. Well, thank you so much, Professor, once again for your time and your expertise. It's been a true pleasure. And we wish everyone a wonderful evening. Thank you once again. And if you've enjoyed this content, please be sure to check out the educational YouTube channel and share this information as well. None of this would be possible if not for the expertise and availability of professors like yourself. So thank you so much. Thank you for everything that you do. Have a wonderful evening, everyone. Bye-bye.